This conference will now be recorded.
మన లెజెండ్ ఎక్కడ వచ్చినట్టు ఆర్కేసీలో
Good morning. Am I audible? Hello.
Yes, sir.
So today we'll discuss about Addison's disease. What is Addison's disease? So he is Thomas Edison, British physician, who discovered this. First identified the cases of this Addison's disease. So today's objectives are to enumerate clinical scenarios to suspect Addison's disease. So when to suspect Addison's disease, and order and interpret test and to diagnose them, and how to manage the case of Addison's disease and adrenal crisis. It's a rare chronic endocrine disorder characterized by deficiency of steroid hormones, glucocorticoids, and often mineralocorticoids. So it's a deficiency of steroid hormones, and it can also present as life-threatening crisis if not recognized in early stages. So the adrenal gland consists of capsule, adrenal cortex, and medulla. The capsule and the cortex consists of 3 layers: zona glomerulosa, zona fasciculata, and zona reticularis. And adrenal, these 3 layers constitute the adrenal cortex. The glomerulosa, fasciculata, and reticularis, and adrenal medulla which release secrete catecholamines. Then the glomerulosa secrete aldosterone, fasciculata glucocorticoids, and reticularis produce androgens, and the medulla produce catecholamines. So adrenal gland produces these hormones. So the incidence is about 1 per 1 lakh population, and the prevalence is 4 to 11 per 1 lakh population. It typically affects adults between 30 to 50 years of age, and no difference in gender or ethnicity. Autoimmune adrenalitis is slightly more common in women. So there is a hypothalamo-pituitary adrenal axis. So how you will identify the patient of adrenal crisis? So typically the patient comes to you with weight loss, fatigue, tiredness, weakness, or non-specific symptoms. I will come again all those what is the symptomatology or the clinical features. So and patient will having pigmentation on his dorsum of his hand or legs, and also in a buccal palate. So there will be typically the pigmentation. So why there is pigmentation in Addison's disease? Because whenever the cortisol releasing hormone produced from the hypothalamus act on pituitary and produces ACTH, adrenocorticotropic hormone, which acts on adrenal gland to produce the steroid hormones. Whenever there is deficiency in steroid hormones, there will be no negative feedback. The ACTH will be raised. So whenever there is increase in ACTH, they act on melanocortin 1 receptors on the skin, and they produce pigmentation. So it is seen in primary Addison's disease, not the secondary. Primary means the problem, the pathology is in adrenal gland. Secondary is the pathology is in pituitary. So the pigmentation is due to a raised ACTH levels. So clinical features include pigmentation. Most obvious feature that differentiate primary from secondary hypoadrenalism. It is seen in sun-exposed areas, recent rather than old scars, axilla, nipples, palmar creases, pressure points, mucous membrane, buccal, vaginal, vulval, and anal mucous membranes. So you can see the typical picture of pigmentation present in the buccal palate. See the black pigmentation, and you can see the pigmentation here also. So the regulation of cortisol secretion. So whenever there is stressors like hypoglycemia, hypotension, fever, or trauma, there should be rise in the stressor hormones like cortisol. So the hypothalamus releases cortisol releasing hormone, and then ACTH, and then which ACTH from pituitary, and which acts on adrenals and produce cortisol. This cortisol produces negative feedback on ACTH and also in CRH. So that's why if there is deficiency of cortisol, there will be no negative feedback, and there will be excess of ACTH, which acts on melanocortin 1 receptors and produces the pigmentation. So if you, what happens if you give exogenous steroids in prolonged duration? So if you give exogenous steroids for prolonged duration, the endogenous production of this cortisol will be reduced, and the amount of cortisol which is given is sufficient to inhibit the ACTH and CRH. So whenever there is hypoglycemia, hypotension, fever, trauma, the cortisol should be in excess to maintain our basal metabolic BMR, and also all our biochemical activities. So for I will come again to this topic again. So zona glomerulosa secreting aldosterone, fasciculator and reticularis. Fasciculator producing, can you tell me what zona fasciculator produces? Cortisol, you can type the answers in chat box also. Reticularis, sex hormones. So whenever there is decreased renal arterial pressure or increased beta adrenergic action, or increased prostaglandins. So whenever there is a fall in blood pressure, renal arterial pressure, fall in blood pressure leading to renal arterial pressure, the kidney secrete renin. The renin converts the angiotensinogen into the angiotensin 1. Angiotensinogen produced from the liver into angiotensin 1. The angiotensin 1 is converted in the lungs to angiotensin 2, which produces aldosterone. Angiotensin 2 acts on adrenals and produces aldosterone. So aldosterone causes sodium and water retention and potassium and H+ excretion. So aldosterone causes sodium and water retention, so to maintain the renal arterial pressure, and potassium and H+ excretion. So it leads to excess of aldosterone leads to hypokalemia and hyponatremia. So sodium and water retention, potassium and H+ excretion. So what are the clinical features? The symptoms include weakness, tiredness, fatigue. So 100 frequency, you can see the almost 100% of cases, you can 100% of the patients you can see these non-specific symptoms: weakness, tiredness and fatigue, anorexia. And the next this next is GI symptoms: the nausea, vomiting, constipation and abdominal pain, postural hypotension, postural dizziness and muscle or joint pains. And the most common sign is weight loss, hyperpigmentation, hypotension, vitiligo and auricular calcification. So what is the etiology of Addison's disease? So I told you deficiency of adrenal hormones. So primary causes and secondary causes. The primary causes include adrenal dysgenesis, adrenal destruction, impaired steroidogenesis. So adrenal destruction can be due to infections, tuberculosis, fungal infection, cytomegalovirus and HIV, or autoimmune adrenalitis, or metastatic tumors and infiltration, any infiltrative. So any etiology we can divide for the For etiology, we can differentiate into, it can be due to autoimmune, infection, tumor, and infiltration. Just remember these 4 headings. It will be very easy to you. So infection, autoimmune, tumor, and infiltration. And another cause will other are intraadrenal hemorrhage, which is seen in the patient in a case of atrial fibrillation on anticoagulation like warfarin. If there is an excess dose of warfarin, it may lead to the bleeding all over the body. So sometimes if the bleeding is present in adrenal gland, it may lead to intraadrenal hemorrhage and present as adrenal ADDISON's disease, adrenal hypoadrenalism, or sepsis, pseudomonas infection. So if meningococcal septicemia, it can lead to the adrenal gland destruction, which is known as Waterhouse-Friderichsen syndrome. I repeat, it's a Waterhouse-Friderichsen syndrome, which is due to meningococcal septicemia. And APLA, antiphospholipid antibody syndrome, which can also lead to the bleeding or thrombosis of the vessels. It also leads to the hypoadrenalism. And medications like aminoglutamide, ketoconazole, and etomidate. So what are the other etiologies? Till now I had told you the adrenal destruction. Now impaired steroidogenesis, that is impaired production of the adrenal hormones, which due to congenital adrenal hyperplasia. The most common important one is 21 hydroxylase deficiency and 3 beta hydroxysteroid dehydrogenase deficiency and level beta hydroxylase deficiency. So other causes include APS1, autoimmune polyendocrine syndrome 1, and autoimmune polyendocrine syndrome 2. One is seen in children mainly, 2 is seen in adults. It is seen in 1 in 9,000. APS2 is seen 1 in 20,000. It includes hypoparathyroidism, mucocutaneous candidiasis, all the autoimmune disorders, autoimmune polyendocrine syndrome. So multiple endocrine glands are involved due to the autoimmunity. Next, autoimmune thyroiditis, diabetes, hypogonadism, and adrenal insufficiency. So these are the causes of these adrenal insufficiency syndromes. Then AAA syndrome, which is achalasia, alacrimia, and adrenal insufficiency. AAA syndrome. Then mitochondrial insufficiency, lactic acidosis, cataract, myopathy, and short stature. Then secondary causes. Secondary causes are not due to the problem. The pathology is in pituitary. So sudden withdrawal of exogenous steroid therapy, hypopituitarism, pituitary surgery. I told you for any etiology, differentiate into the infection, tumor, autoimmune, infiltration. So infections like tuberculosis, sarcoidosis, tumors, secondary bronchus tumors with mets. Then pituitary irradiation and multiple pituitary hormone deficiency, HEXS1, LHX4 mutation. Then pituitary apoplexy, which is seen in and postpartum pituitary postpartum pituitary infection, which is Sehan syndrome, which is seen in postpartum period in females. So it's the typical pigmentation of the hands, you can see. So lab findings include electrolyte disturbance, hyponatremia, hyperkalemia. I told you aldosterone causes sodium and water retention and potassium and H+ excretion. So if the aldosterone is excess, it causes hypokalemia. If aldosterone is deficient, it causes hyperkalemia. So hyponatremia, hyperkalemia, hypercalcemia, azotemia, anemia. Azotemia means rise in blood urea nitrogen levels or blood urea nitrogen. If the patient having symptoms with elevated blood urea nitrogen, then it is called uremia, which is seen in AKA or CKD. And eosinophilia, lymphocytosis, and high plasma renin and or increase in nighttime ACTH level and recurrent hypoglycemia. The patient may present all these lab findings. So diagnosis of primary adrenal insufficiency includes the baseline cortisol level should be less than 5 microgram per deciliter and ACTH concentration should be more than 100 picogram per ml. Then because the cortisol steroids are deficient, they will be very low in this adrenal insufficiency. So send cortisol preferably at 8 a.m. and send serum cortisol before administering hydrocortisone. For example, now in COVID patients, we are giving the steroids regularly whenever there is indication in second week. So when we are giving steroid, if a patient is if you suspect any adrenal insufficiency in this patient, so you can't send the sample before after giving the hydrocortisone, because it will give a false negative result. So you have to send the sample before administering the steroid. And what is synactin test? ACTH test. Synactin ACTH. So ACTH stimulates the adrenal gland to produce cortisol. So it's a synactin is a synthetic ACTH. The synthetic polypeptide synactin, which is a tetracosaccharine structure identical to ACTH, is screening test used to stimulate the production of cortisol. So first, how to do this test? At 0 minutes, insert one cannula, give synactin IV or IM and flush in well with saline. The dose is 250 micrograms. Then send the blood sample for cortisol at 30 minutes and 60 minutes. So the normal response is, if you give synactin, the normal response should be there should be rise in cortisol levels. So it should be normally the peak cortisol value post stimulation should be more than 18 microgram per deciliter. But if in critical illness, which means a patient is in ICU in critical illness or ventilator, which is a very major stress levels. So patient will be having high cortisol levels. So in critical illness, if it is less than 15 microgram per deciliter, it is insufficiency, and it is more than 33, it is normal. So, but in normal patients, if cortisol levels, random cortisol are less than 5, it is adrenal insufficiency. So in synactin test, if it is more than 18, this is normal. If it is less than 18, you have to suspect the adrenal insufficiency. So treatment include give the steroid hydrocortisone 15 to 20 mg morning, 5 to 10 mg early afternoon, and prednisolone 5 to 7.5 mg per day. And fludrocortisone, melanocorticoid 0.2 mg per day, liberal salt intake, and issue a medical alert card. And monitor BP, ACTH, serum potassium education. Why the medical alert card? Because whenever he comes to any casualty with any medical problem, we can correlate and we won't stop the prednisolone. So if a patient wants to do a surgery, hernia surgery for that patient, or any major surgery, we should not stop the prednisolone dose. We should increase the dose at a time, because the stress, the surgery is a stressful state. So they require more amount of steroid, because patients' endogenous production of steroids are absent. So we have to give additional dose. That's why we have to issue a medical alert card. So I have one patient who came with pain abdomen and fever. So he came to casualty. He's very bulky and he seems very muscular. So he's a very healthy. So, and he's having diffuse skin rashes all over the body, which are round, very big rashes. So when we examined him and we took history, it turned out to be patient is having appendicitis, which is a very atypical presentation. We're having diffuse abdominal pain, and the radiologist report has given wrong to us at the initial first day. So, and also derma referral on the skin rashes, they told the patient is having very atypical rashes which are not normal, which may be probably the patient is on steroids, because the patient's skin is thin and he's having a very muscular build. Then we asked him what he's doing. So he told he was going to gym regularly, and someone told to take steroids so that his body will get built up easily. So again we joined, we took the history. Then it turned out to be he was on a steroid addiction. He's taking those steroids. So the patient presentation will be different if the patient is having secondary adrenal insufficiency. See, he's having atypical skin rash, he's having a mild fever, but a very severe infection in his body. So again, they did surgery, which was gone well. And but important thing is, during surgery, though there is a mild infection, we have to give replace steroids we have to give steroids to him. Why? Because the endogenous production of steroids are absent. So we have to maintain his steroid state. So that's why it's very important to take the history. So people won't tell you why. People won't tell you that he is taking steroids from long time. In case in this patient like who is on bodybuilding exercise competition. So secondary adrenal insufficiency. So replace steroids first. So secondary adrenal insufficiency means the pathology is in pituitary. So there will be associated other hormone deficiencies of thyroid and growth hormone are associated deficiencies. So replace steroids first and then thyroxine. Then Addisonian crisis may be precipitated if thyroxine is given without steroid. So patient 26 years, primary hypothyroidism, Addison's disease. So advice should be patients who have altrozine, hydrocortisone, vitamin D, calcium, and double the dose of isolone steroid if they have fever, vomiting, and acute illness. Hydrocortisone in case of hypotension, shock, altered sensorium. So imaging etiological diagnosis include ultrasound, CT. So then these are the pair of adrenals. The image shows the pair of adrenals in center are normal, and those top come from the patient with adrenal atrophy, either with Addison's disease or long-term corticosteroid therapy. The adrenal at the bottom represents bilateral cortical hyperplasia. Caseating granuloma of the tuberculosis in adrenal gland. Tuberculosis is used to be the most common cause of chronic adrenal insufficiency. So what is Addisonian crisis? It is a life-threatening condition characterized by acute deficiency in steroid hormones. Steroid withdrawal is the most common cause and almost exclusively cause a glucocorticoid deficiency. So what I told the example of the patient I told is a typical case of Addisonian crisis. So may result from acute exacerbation of chronic insufficiency, usually caused by sepsis or surgical stress. Can be caused by adrenal hemorrhage. With septicemia induced Waterhouse-Friderichsen syndrome, fulminant meningococemia, and anticoagulation procedures. So what are the features of adrenal crisis? Dehydration, hypotension, shock, out of proportion of severity of current illness, nausea and vomiting, abdominal pain, so-called acute abdomen. The patient may present as acute abdomen. Unexplained hypoglycemia, unexplained fever, hyponatremia, hyperkalemia, azotemia, hyperpigmentation or vitiligo, other autoimmune endocrine deficiencies as hypothyroid and gonadal failure. So this is the features I had told you previously. Shock, anorexia, abdominal pain, weakness, fever, confusion, coma, or dehydration, hypotension, and shock. Hyponatremia and hyperkalemia might be obscured by dehydration. So random cortisol is not helpful unless it is very low during the period of gate stress. So management of Addisonian crisis include hydrocort, give 100 mg IV stat, then 50 mg fourth hourly for 24 hours, taper slowly over 72 hours. So first give the 100 mg, then 50 mg fourth hourly for 1 day, then taper slowly. Replace salt and fluid loss with 5% dextrose in normal saline. So whom to suspect? When the patient is emaciated, ill, weight loss, and tuberculosis and are immunocompromised patients, persistent hyponatremia even without diuretics, serum cortisol at 8 a.m., synaptic stimulation test less than serum cortisol at 8 a.m. less than 5, synaptic stimulation test 8 less than 18 picogram, then replace hydrocortisone. Which of the following is normal adrenal reserve response to 250 microgram synaptic stimulation test? Cortisol value more than 18, 10, any value greater than basal cortisol value, doubling of serum aldosterone. What is the answer? I think no one is listening.
A.
Okay, good. A. Which of the following is not a feature of Addison's disease? hyperkalemia, skin pigmentation, salt craving, orthostatic hypertension.
Orthostatic hypertension.
Hypertension.
Come again, repeat it. Orthostatic.
Hypertension.
So it's a orthostatic hypotension. Hypertension. Okay, good. 55-year-old lady with valve replacement on warfarin admitted in the ICU with sepsis. Went into shock on third day. It on 3 anatropes. BP did not stabilize. Autopsy showed like this. What is the likely diagnosis? Yeah, I told you about this. Patient is on warfarin, so there will be increased
Adrenal
bleeding risk.
hemorrhage, sir.
So you can see that there is a adrenal gland showing
Hemorrhage.
shows a bleeding clots in this. So it's a adrenal hemorrhage secondary to the warfarin. So we should use steroids in this patient at that time. Thank you. Is everybody listening to the classes, or only a few people are listening? Okay.